Good afternoon, everyone. Good afternoon. Thank you for joining us this afternoon for one of the last sessions of the day. We hope everyone has enjoyed the fruitful sessions over the last 2 days. Today, we will be taking a deep evidence-based look at the integration of internationally educated health professionals, IEHPs, and what it means for Canada's future health workforce. This conversation sits at the intersection of settlement practice, labor market policy, and human resource planning for the health sector. Our goal is to bridge these perspectives and explore what coordinated, equitable integration could look like in this practice. So throughout the session, we ask that you reflect on where your organization sits within the systems that we are discussing today. So before we go any further, who are we? My name is Danielle, and I am the Chief Program Officer at the Ottawa Community Immigrant Services Organization, which we refer to as OCISO. So OCISO has supported newcomers in Ottawa since 1978 and serving roughly about 10,000 clients a year. OCISO is rooted in trauma-informed, culturally responsive practice. Our program spans settlement, mental health, employment, youth, language instruction, and community development. And I'll pass it over to my colleague, Min, to introduce the PICS organization.
Thank you. Good afternoon, everyone. My name's Min, and I'm currently working at the Progressive Intercultural Community Service PICS Society. That's based in Surrey, in British Columbia. And we are a nonprofit organization founded in 1987. And we are currently offering more than 60 free programs, which includes employment, settlement, language services, social program, housing, career services, and many others. And our clients are from, youth, people with disability, Indigenous people, skilled immigrants, seniors, and refugees. Thank you.
Thank you, Min. So in terms of meeting the team and the speakers for today, so as I mentioned, my name is Danielle, the Chief Program Officer at OCISO, and I've worked across multiple program streams, including settlement, employment, mental health, and youth. And I am joined today by my colleagues and presenters, Ayla Kezar, who is the manager of the Community Economic Development Program, known as CD, at OCISO. I'm also joined by Chandrika Mohan, the program manager for the FCR IEHP program at PICS, and Minshro, which is also one of our presenters, who is the marketing and outreach officer at PICS Society. Okay, so here's a roadmap for today's session. So we'll start with national IEHP trends and workforce projections, then examine provincial approaches, regulatory barriers, and emergent innovations. We'll also look at settlement sector's unique role and how it plays with the IEHP, not just as service providers, but as connectors, advocates, and system navigators. Finally, we'll reflect on what sustainable coordinated integration could look like at scale. So keep in mind as we go through the session that the session is as much about systems as it is about the people within those systems. So in regards to the federal Foreign Credential Recognition Program overview, this tri-provincial FCR IEHP program was designed to reduce the credentialing barriers and support pathways into regulated and unregulated health roles. What distinguishes this from other programs is the combination of the credential alignment, the support, and the on-the-ground community-based navigation. This program contributes not only to the individual success, but also to the broader labor market efficiency. So this model is intentionally holistic. We look at needs assessment, counseling, credential navigation, job readiness, mentorship, volunteering, and employer engagement. We offer paid work experiences through wage subsidies, a critical bridge in professions where Canadian experience barriers continue to persist. We center on the newcomer needs through wraparound supports, recognizing the nature of the labor market barriers. And importantly, we support interprovincial mobility, which is one of the most significant structural levers for reducing health system shortages. So our favorite part, let's look at some numbers. So in 2021, over 259,000 internationally educated health professionals were living in Canada. This is a massive pool of talent. Health occupations make up 8.1% of the national workforce, and nearly 18% of those workers are nearing retirement. This represents a structural gap. The demand for health professionals is rising faster than our ability to train and retain these workers. IEHPs are not just potential contributors, they're essential to system sustainability. So let's take a pause for a second and let the weight of those numbers sink in. Okay, so there are three principles that guide effective IEHP integration. Sustainability, which is looking at long-term funding, stable pathways, and cross-sector alignment. Inclusion, which centers on IEHP's lived experiences in the program and policy design, as well as responsiveness, which is looking at adapting to shifting regulatory requirements, pre-arrival realities, and labor market needs. These principles reflect both academic frameworks and what frontline practitioners have consistently observed. So although 76% of IEHPs are employed, only 58% are working in their trained profession. Ontario is home to 41% of all IEHPs, yet faces some of the most acute shortages. This disconnect between the skills and licensure is what researchers call brain waste, a systemic underutilization of talent with measurable economic consequences. So let's look at some of the numbers and how we can put this into practice. We're going to look at a case study. So Maria is a nurse from the Philippines, and she arrived with 10 years of experience. She was initially lost in the credential maze, and she visits a settlement agency. So through coordinated referrals, a career counselor, language training, mentorship, and a bridging program, she regains her license within 2 years. And today, Maria mentors new IEHPs through that same agency. So Maria's experience mirrors findings across multiple studies. Qualified IEHPs arrive with strong experience, but the credentialing pathway is opaque and fragmented. Her success came from coordinated supports. She regained her license in 2 years, and again, like I mentioned, she now mentors others. This illustrates that when the systems align, IEHP integration accelerates exponentially. This is a micro story that reveals macro issues. So breaking down Maria's journey further, we look at the arrival. She's skilled, she's motivated, and she's experienced. We look at the barrier, regulatory complexity and system confusion, support, coordinated multi-sector navigation, and the outcome, full license and peer leadership. Her trajectory showed how integrated supports transform individual potential into system benefits. Now let's zoom out and look at the broader community impact. IEHPs enrich local health systems, particularly in rural and newcomer-dense areas where shortages are most severe. Their cultural and linguistic competencies directly improve patient trust, outcomes, and continuity of care, all well supported by literature and research. Successful IEHP integration also stabilizes families, increases income security, and strengthens the community well-being. This is both a workforce strategy and a community development strategy. Settlement organizations, the work that we are doing, serve as essential bridge institutions. We offer culturally safe, holistic supports, childcare navigation, housing, system literacy, mental health, and career roadmaps. These services and employers are not structured to provide, but without them, pathways collapse. The settlement sector is not supplemental, it is foundational. Canada's health workforce remains under extreme strain. Health Canada's national modeling confirms ongoing shortages in family medicine, nursing, and pharmacy. Even with current training output, Canada will not close these service gaps within the next decade. The Canadian Medical Association estimates a deficit of approximately 823 family physicians, while RBC Economic projects an overall shortage of about 44,000 doctors by 2028, with family physicians accounting for roughly 72% of that gap. Similarly, the Fraser Institute projected that physician-to-population ratio would rise only marginally from 2.74 per 1,000 in 2015 to 2.97 in 2030, remaining well below the Organization of Economic Cooperation and Development average. Its mission is to provide our Organization for Economic Cooperation and Development mission is to promote economic growth, stability, and improve quality of life through policy research, data collection, and collaboration amongst countries. For nursing, Canada forecasted a deficit of 37,000 registered nurses by 2028. In Ontario alone, the Registered Nurses Association of Canada reported that the province requires approximately 26,000 additional RNs to reach the national per capita ratio. In Ontario alone, the registered, yes. Right. Canada's aging population is driving a steep rise in demand for family medicine, nursing, and allied health services, especially for chronic disease management and long-term care. The supply of health professionals is not keeping pace with demographic change. As older adults require more continuous and complex care, the gaps in primary and community-based services continue to widen. Rural and northern regions face proportionally greater deficits, amplifying inequities across in access to timely care. In these areas, shortages in family physicians and nurses often mean reduced service hours, emergency department closures, and longer travel distances for patients, which we've all heard about within the last few years. So in terms of what our call to action would be, the intersection of population aging and the chronic disease prevalence with workforce shortages represents a systemic stress point, one that can be mitigated by better integrating IEHPs into practice-ready roles. So let's look at some geographic disparities. Workforce distribution across Canada remains profoundly uneven. Despite national investments in training and recruitment, most health professionals continue to concentrate in large urban centers, leaving rural and remote regions persistently underserved. Between 2013 and 2022, the share of nurse practitioners working in rural or remote communities fell from 18% to 14%. Pharmacists declined slightly from 11% to 10%, while family physicians in those regions remained around 13%. In the combined Northern Territories, only about 46% of internationally educated health professionals were employed in health occupations, compared to 67 to 74% in several Atlantic provinces. In Ontario, the urban-rural divide is even more pronounced. While the province hosts nearly 45% of all IEHPs, most are concentrated in the Greater Toronto Area. The Ontario College of Family Physicians projected that by 2026, approximately 4.4 million Ontarians would be without a doctor. That is a vast number. How are we addressing this, and what is our call to action? Addressing these regional gaps requires targeted workforce planning, including supervised practice placements for IEHP in northern and rural areas, relocation incentives, and provincial coordination to align licensing processes with local needs. So that scary word, COVID-19, and its impact, it keeps resurfacing. So the COVID-19 pandemic intensified pre-existing workforce fragility. According to the Canadian Institute of Health Information, hospital providers logged more than 26 million overtime hours in 2021 to 2022. That's equivalent to 13,000 full-time jobs and 22.6 million hours in 2023 to 2024. The Canadian Federation of Nurses Union reported that nearly 45% of nurses reported that they were considering leaving the profession within 1 year, and more than half of Canadian physicians met the clinical criteria for burnout. In 2024, the Registered Nurses Association of Ontario reported that in Ontario, the situation was particularly concerning. Hospitals reported vacancy rates nearing 10% in emergency and intensive care units, and identified the need for at least 26,000 additional nurses to stabilize staffing. Several rural hospitals have experienced repeated emergency department closure due to shortages. As more workers reduce hours or leave the profession, shortages deepen, forcing greater reliance on overtime, agency staff, which increases operational costs by 30 to 50%. Burnout has become the key driver of attrition in Canada's health workforce. Nearly half of nurses and over half of physicians reported symptoms consistent with burnout. The cycle of stress, vacancies, and expense destabilizes care delivery, especially in hospitals and long-term care. Integrated internationally educated health professionals through expedited licensing and supervised practice models is a sustainable way to relieve the pressures, fill vacancy, and stabilize the systems long-term. So what is the cost of inaction? According to the World Education Services, despite chronic shortages, nearly 47% of IEHPs remain unemployed or underemployed relative to their qualifications. This misallocation of talent has direct economic consequences. RBC Economics estimates that the underuse of immigrant skills costs the Canadian economy up to $50 billion annually in lost productivity. Within healthcare, each year of delayed licensing translates into higher overtime costs, heavier workloads, and prolonged patient time. For example, the Canadian Institute of Health Information reported that excessive overtime hours in hospitals alone equal the work of more than 13,000 full-time staff, capacity that could have been filled with licensed IEHPs. In Ontario, home to nearly half of the IEHPs in Canada, many internationally trained physicians and nurses remain in survival jobs, while hospitals experience record high vacancies. Each unrecognized profession represents not only lost income and morale, but also an avoidable strain on public resources. So fully integrating IEHPs through bridging programs, supervised practice, and fair credential recognition could yield measurable fiscal savings and directly alleviate the health workforce crisis. IEHPs are immigrants who earned their highest post-secondary credentials in a health-related field outside of Canada. They bring diverse global experience and disciplines such as medicine, nursing, pharmacy, and allied health, often having practiced in complex healthcare systems before immigrating. IEHPs represent a critical but underutilized resource for addressing Canada's healthcare labor shortages. They can bolster overstressed hospitals, primary care and long-term care systems, particularly in rural and underserved regions. Their integration can contribute not only to improved patient access and cultural competence, but also to economic productivity and health system sustainability. According to Statistics Canada, in 2021, there were approximately 259,695 IEHPs aged 16 to 64, representing about 30% of all Canadians with post-secondary health education. Nearly half reside in Ontario, followed by British Columbia, Alberta, and Quebec. About 71% are women and 2/3 are under age 50. Internationally educated nurses comprised of 12% of newly licensed nurses in 2022, up by 8% in 2017, a sign of gradual but insufficient progress. Despite their qualifications, many IEHPs face licensing barriers, prolonged credentialing processes, and limited access to bridging programs. As a result, thousands remain in survival jobs unrelated to their training. This mismatch between skills and employment not only limits individual potential, but it also weakens Canada's ability to respond effectively to an ongoing workforce crisis. So in terms of the pathways to practice for IEHPs, physicians can pursue two main pathways to practice in Canada. The first is the traditional residency route via the Canadian Residency Matching Service after passing the MCCQE1, which is the Medical Council of Canada Qualifying Examination Part 1, and the National Assessment Collaboration Examination, often called the NAC OSCE. The second is the Practice Ready Assessment route, the PRA, in which internationally trained physicians complete a 12 to 16 week of supervised practice in approved sites across the provinces such as British Columbia, Saskatchewan, Nova Scotia, and Ontario. For nursing, bridging and supervised practice programs such as the Supervised Practice Experience Partnership, SPEP, allows internationally educated nurses to meet licensure requirements while gaining paid experience. Ontario's new Practice Ready Ontario PRO program aims to license up to 100 family physicians by the end of 2025. These are proven, scalable solutions that can be expanded nationally to help meet the urgent healthcare needs. Scaling practice-ready assessment and supervised practice experience partnerships can unlock thousands of skilled professionals already living in Canada. So how do we facilitate this? What is the call to action? So it requires collaboration amongst the government, regulators, employers, and educational institutions. With the right investment and coordination, we can achieve safe, rapid, and sustainable integration of IEHPs, benefiting both the health system as well as patients. So what is the reality of IEHP in Ontario? Ontario hosts the largest share of IEHPs in Canada, approximately 116,000 professionals, but only a fraction of are licensed to practice. On average, internationally educated physicians take 3 to 5 years to reach independent practice, while nurses require 18 to 36 months. The cost of licensing can exceed $16,000 for nurses and $20,000 for physicians, not including lost wages during assessment periods. While waiting for recognition, nearly half of IEHPs earn less than $30,000 annually. Many work in low-wage jobs unrelated to their field or unpaid observerships to maintain clinical relevance. These economic pressures interact with housing insecurity, limited childcare, and cultural adjustment stressors. These barriers are not only procedural, but structural. Licensing authorities often require recent Canadian experience. We've all heard about that, creating a circular barrier for newcomers who cannot obtain that experience without a license. So again, what is our call to action and how can we look at putting some solutions in place? Accelerating supervised practice programs, expanding supervised practice programs, PRA seats, and subsidizing bridging tuition would allow Ontario to leverage its existing skills workforce to fill current vacancies, an economically sound and socially equitable strategy. As mentioned previously, in terms of barriers to IEHP, licensing can cost a lot, between $10,000 to $16,000 for nurses and up to $20,000 for physicians, including exam fees, bridging tuition, language testing. Processes often duplicate themselves, varying by province, and can take several years to complete. Systemic barriers such as language bias, lack of supervised placements, and limited mentorship delay entry. Intersectional factors compound these challenges. More than 70% of IEHPs are women who frequently balance caregiving with full-time survival jobs while navigating credentialing systems. Racialized IEHPs often encounter additional discrimination or exclusion from informal professional networks. So some solutions and recommendations. Looking at establishing a national framework for consistent, transparent, and efficient licensing across provinces. Reducing duplication by allowing reciprocal recognition of assessments and credentials. Scale up paid practice-based placements to allow IEHPs to demonstrate competence while contributing to care delivery. Provide micro-credential options to fill small knowledge gaps rather than forcing full retraining. Offering targeted bursaries or low-interest loans for exams and tuition costs. Support employers and preceptors with incentives to host IEHPs in clinical environments. Mandate cultural competence and anti-bias training for regulatory and hiring bodies. Strengthen mentorship networks, pairing IEHPs with licensed professionals. Integrating IEHP data into health human resource strategies to align licensing capacity and staffing shortages, and recognize IEHPs as a core solution to addressing Canada's healthcare workforce crisis. According to the Canadian Institute for Health Information, in 2022, more than a quarter of physicians, about 26%, were international graduates. And the average proportion of newly licensed nurses who were internationally educated was 12%. We're looking at data internationally. The UK, 30%. Are doctors, 22% nurses are foreign trained. Australia has 36% doctors and 25% internationally educated nurses. And New Zealand, 40% of physicians are trained abroad. These data points illustrate the significant contribution of internationally educated health professionals to major health systems in high-income countries. The variation between countries is substantial. For example, UK's higher reliance compared to Canada's lower figure for nurses. It suggests that the workforce planning for health systems must account for the mobility of health professionals and the global training market. The difference between doctors and nurses also matters. Internationally educated doctors tend to make up a higher proportion in some systems than internationally educated nurses. For countries like Australia and New Zealand, these figures shown suggest a very high reliance point to strong international recruitment or retention of foreign trained staff in these systems. So what are our policy implications? Integrating IEHP in both equity and economic is extremely imperative. Streamlining credentialing, expanding supervised practice, and providing financial support for bridging programs could help Canada mobilize thousands of qualified professionals already living in the country. Health Canada emphasizes that practice-ready and supervised models are safe and cost-effective when properly regulated. Removing intersectional barriers and implementing coordinated national data tracking will also strengthen evidence-based workforce planning. So Canada's healthcare system is at a turning point. Across provinces, we face deepening shortages in family medicine, nursing, and allied health, while thousands of internationally educated health professionals who are already here remain underemployed. This challenge is not a lack of skill or motivation, it is a lack of accessible, evidence-based pathways to let qualified professionals contribute safely and efficiently. So we already have our blueprints, right? We have practice-ready assessments, has enabled hundreds of internationally trained physicians to demonstrate readiness and enter independent practice in Canada safely, efficiently, and in underserved communities. Supervised practice experience partnerships provide internationally educated nurses the chance to prove competence through supervised hands-on practice rather than repeating full academic programs. Both models are competency-based, validated by regulators, and proven to protect patient safety while accelerating workforce entry. They are trusted pathways. They're efficient, they're scalable, and they're retentive. Participants all often stay in communities where they train. This improves the access and retention. Up to $50 billion a year is lost due to underutilized IEHP skills. Integration recovers this value. The PRA and the SPEP reduces burnout, agency cost, and regional inequities. Over 100,000 internationally educated health professionals are already in Canada. Integrating them strengthens care delivery, reduces wait times, and saves billions. Recognition and opportunity, not retraining, are the key to this success. So what would be the national benefit, and how are we facilitating this equitable access? So we need to expand placements in rural and underserved regions. We need to pair integration with incentives and retention support. Diversity and inclusion are workforce strengths, not side goals. The broader policy opportunity, scaling PRA and SPEP nationally aligns perfectly with our broader workforce goals. We want to stabilize staffing through faster integration of IEHPs. We want to reduce burnout and agency dependence by easing workload pressures. We want to address rural inequities through community-based placements and incentives. And we want to unlock underutilized talent, turning economic loss into system strengths. Every IEHP successfully integrated is both a workforce solution and a social investment, improving access, diversity, and sustainability. So overcoming barriers. To fully realize this potential, we must remove those structural barriers. Credential recognition, standardize, simplify, and speed up the assessment process. Financial barriers, offer bursaries, free waivers, or low-interest loans for exams and licensing cost. Equity and inclusion, embed anti-bias measures, mentorship, and childcare support to ensure fair access. Policy coordination, align immigration, education, and health workforce planning under a unified federal provincial framework. So key recommendations, the workforce challenge. Health Canada and national forecast predict a deficit exceeding 40,000 physicians and 37,000 nurses by 2028. Ongoing burnout, overtime, and attrition threaten to destabilize care delivery. Without reform, millions will lack access to primary care by 2030. We need to expand and expedite IEHP integration through supervised practice, bridging programs, and targeted provincial partnerships. Geographic disparities, most healthcare professionals, including IEHP, cluster into major urban centers. Rural and northern communities remain critically underserved. So introduce relocation incentives, housing assistance, and rural-based supervised practice placement to attract and retain IEHPs outside of the metropolitan regions. System strain and burnout. COVID-19 exacerbated staff shortages, driving costly overtime and dependence on agency workers. Integrating IEHPs offer immediate relief. Recommendation: recognize IEHP integration as a workforce stabilization strategy. Expand supervised practice and mentorship programs to mitigate attrition and burnout. Economic loss and underutilization. Canada forfeits an estimated $50 billion annually due to underused immigrant skills, licensing delays, prolonged wait times, and increased overtime costs. We need to implement national standards for credential recognition, subsidize licensing and exam fees, and streamline bridging pathways to maximize return on human capital. Licensing remains costly and slow, particularly on Ontario. IEHPs, 70% of whom are women, face language, cultural, and discrimination barriers. We need to harmonize regulatory processes across the province, introduce financial aid, childcare, and mentorship programs, and embed anti-bias measures in professional assessment. Ontario is a pilot for national reform. Ontario, home to nearly half of Canada's IEHPs, can lead by example. The Practice Ready Ontario and Supervised Practice Experience partnership models demonstrate scalable, safe integration routes. Expand PRA and SPEP capacity, provide fee waivers, and create centralized job matching systems, linking IEHPs with high-need facilities. And policy and governance framework. Integrating IEHPs is both a moral and economic imperative. Coordinated data collection and equitable credentialing will enable sustainable workforce planning. So recommendations: we need to establish a national IEHP integration strategy under Health Canada. Develop a federal database tracking IEHP licensing, employment, and mobility. And very, very important, align immigration, education, and health policies for long-term workforce resilience. Thank you very much. And with that, I would like to share a video of one of our IEHPs who is participating in our program before I pass it over to my colleague, Min.
My name is Nasser Mhawish. I'm originally from Syria. Back in Syria, I specialize in general surgery, but with the war happening and with all the conflict escalating there, I had to leave the country. But it was mentioned that OSISO is providing more concrete, focused support to internationally trained health professionals. Being an IMG myself, that intrigued me more, and I collected the courage, and I contacted, and I'm really lucky that I contacted, and immediately I got a response, and promptly. That was an amazing thing, and it helped me. But aside from the direct technical support that I'm receiving with inquiries that I had, there was some workshops for the resume upgrading and development. There were some workshops for the Canadian work environment and Canadian work culture, which is an important thing, honestly, to go through. I had other support for the psychological aspects for the international medical graduates, especially with having to either do a career shift after coming here or to wait for prolonged periods of time until the verification process and all the equivalence process happening. So that was also one of the important things that I received with support from OSISO. And by completing some of the steps, there was a subsidy provided as an offer from OSISO supporting the hiring agency for me if they want. That can be supported by OSISO. I got a few job interviews, and one of the first interviews that I did, I managed to land a job offer, and I accepted that, of course, and I am already working here with my new agency, and I believe that, and I can honestly say that 50% at least of my success in that process was due to the support from OSISO, because the mock interview that I had, the kind of introduction and helping in understanding the mentality and how to deal with the culture here in the work environment in Canada was really helpful for me to make it easier. And honestly, the support by OSISO is amazing. Having this focused approach, this systematic approach, it's not some random thing that comes as an ad hoc kind of support, is really important for immigrants, for those who changed the location from country to country or from continent to continent. In my situation, it's very important to have such support. Continuing with this kind of efforts is pretty important for everyone. It helps the Canadian community by having this kind of modification of what's needed to be modified without forgetting the origin of where we came from. At the same time, it helps us as IMGs or any other kind of health trained professionals to understand what's needed here and to have proper realistic expectations of how to deal with it, which will be reflected in our mental wellness.
Hey, thank you, Danielle, for very good deep scope of the IEHP and what Canada is doing right and what's something wrong and what are the call to actions that we can contribute to the support of IEHP integration. So I'll be discussing about the national and the provincial trends in IEHP integration. And across Canada, the federal, provincial, and the territorial governments are collectively working together to advance the integration of the internationally educated healthcare professionals into the health workforce so that they can work right away. And this coordinated efforts reflects a growing understanding that IHP integration is not an optional. However, it is a key strategy to optimize and expand the our health human resource capacity. First, when we look at it, a major focus has to be the streamlining the licensure pathways. Province and regulators are reducing duplication and simplifying assessment process and expanding the availability of supervised practice options. So the qualified professionals, IHPs, can enter the system a lot faster. In 2024, for example, over more than 1,200 new bridging seats for internationally educated nurses were added across the country, increasing the capacity for clinical assessments and practice-ready training. And the government are also expanding the assessment, bridging, and training programs. And at the federal level, the recent investments last year aim to help more than 6,600 IHPs move through credentialing and into the regulated practice more quickly. This includes the bridging programs, as Danielle mentioned, mentorship, wage subsidized program, loans designed to give IHPs the Canadian experience regulators and employers require. And another priority is targeted recruitment to fill the most critical health human resources gaps. Internationally educated nurses, for example, now make up to 12% of Canada's newly licensed nurses, representing more than 5,000 new IENs in a single year. And this target recruitment supports obviously the hospitals, long-term care homes, and also the rural communities struggling with the chronic vacancies that's happening right now. These actions directly respond to the real system pressures, workforce shortage that we all know, burnout, and uneven. The keyword is the uneven distribution of providers. And the nursing shortages alone grew from 13,000 vacancies in 2018 to 40,000 in 2023, which has intensified overtime, burnout, and turnover across the system. And the IHP integration helps elevate these pressures by bridging skilled professionals into areas of highest need. And another major development is the Health Canada investment in improved labor market data. Through the new national body, Health Workforce Canada, government now have stronger forecasting, better data sharing, and more accurate modeling. This allows immigration programs, licensure pathways, and training capacity to align with real-time workforce needs. And if you have chance to look at it into the Health Canada, you can see all the data across each province and each professions. What are the vacancy, what's the burnout rate, and what's the turnover rate. And all of this is grounded in coordinated federal, provincial, and territorial action. FPT health ministers continue to identify the health human resource stabilization as a national priority, and joint initiatives are designed to meet urgent staffing needs today while improving the long-term system sustainability. Taken together, these national and provincial trends show a unified direction. Canada is building a more responsive, data-driven, and coordinated pathways for IHPNs, recognizing that their integration is essential for a sustainable healthcare system. And I can say that the IEHPs are not a supplementary solutions, but they're the one of the core part of Canada's long-term workforce strategy. Next slide, please. Thank you. National trends. Across this nation, there is a growing recognition that internationally educated healthcare professionals are vital resources in addressing the crisis that we all know. With more than, as she mentioned earlier, there are more than 260 IHPs already living in Canada and thousands more arriving each year. Government now know the view of IEHP integration as one of the most effective strategies to stabilize the health workforce and the solutions of the crisis that we are facing. And to support this, the federal government has a major investment in credential recognition and workforce integration. One of the key mechanisms, obviously, is the Foreign Credential Recognition Program, which funds wage subsidized program services, supervised work placement, mentorship, employer supports, and the loans as well, providing the multiple loans with a lower interest. So IHPs can now transit into the regulated roles more quickly. These programs directly remove the barriers to the Canadian work experience that we all been hearing, which has historically been one of the biggest obstacles to entering the workforce here in Canada. The budget 2024 further strengthened this commitment by announcing that $50 million over 2 years to improve the credential recognition in the healthcare and the construction sector, so the prioritizing the sectors. And this investment supports faster assessments, more bridging seats, and expanded practice-ready pathways, especially important for nursing, allied health, and other high-demand professions across this nation. And in budget 2025, the government has introduced a more than $97 million investment into the Foreign Credential Recognition Action Fund over the 5 years as well. Another important development is Canada's focus on ethical recruitment. Governments are building clear national guidelines to ensure that the international recruitment is responsible, transparent, and aligned with the global health workforce standards. The goal is to protect source countries, providing strong settlement supports for newcomers, and ensure that the IHPs have positive, safe, and sustainable, fair transition into the Canadian system. However, despite the progress, persistent barriers do remain. Many IHPs still face lengthy assessment timelines, limited access to the bridging or a clinical placement opportunities, and inconsistent recognition of the foreign experience across provinces and regulators. Some also do experience delays of months or years before they can practice in their training professions. Employers also report that while IHPs bring strong clinical knowledge, they often need structure, orientation, supervision, and workplace readiness support to ensure long-term retention, which I believe a lot of, I'm sure every service providers are doing to help, especially the skilled immigrants. And these challenges highlight why continued investment, regulatory modernization, and coordination, federal provincial actions are essential. IHPs are not just part of the solution, and they're one of the most critical resources we have already for building a stable, sustainable, and quality health workforce here in Canada. Next slide, please. Here, the provincial trends. When we examine the IHP integration across nation, provincial governments are not taking one-size-fits-all approach. Instead, they're launching tailored strategies that respond directly to their unique health human resource needs. And here are the major provincial trends and how data policy investment show the real progress. The bilateral recruitment agreements and targeted immigration PMP streams. Many provinces are leaning heavily on PMPs, the provincial nominee programs, and occupation target streams to fill the healthcare gaps. For instance, the PMP has grown dramatically from in 2023, 40% of Canada's economic immigrants were admitted through PMP, making it one of the largest components of economic immigration that year, according to Statistics Canada. Provinces like Saskatchewan, Manitoba, and Atlantic Province rely heavily on this program, PNP program. In some cases, up to 85 to 93% of their economic immigrants come via PNP streams. This shows that the PNP program, the provincial nominee program, are not just immigration tools, but they're actively shaping the health workforce by attracting the internationally educated professionals or any internationally skilled immigrants to regions with the shortages that the province and the territorial governments facing. Second one is the expanded practice ready assessment, the PRAs, for physicians and other professionals. In British Columbia, they recently tripled its PRA assessment capacity. Seats increased from 32 per year to 96 annually by 2023-2024. And the expansion of PRABC was part of its border, aligned health, and human health resource strategy, targeting both physicians and allied health professionals. And in Ontario, the government committed to launch a physician PRA that aims to add at least 50 internationally educated physicians by 2024, which hopefully they've been done. And these PRA expansions are crucial because they shorten the time for the internationally trained physicians to start working and reducing one of the largest bottlenecks in IHP integration. And the third point, we're talking about streamlined pathways and bridging credential recognition programs. In BC, British Columbia, they're investing heavily in bridging education for internationally educated nurses. And under its health human resources strategy, the province committed more than $68 million to expand the transitional or remedical education, increase bursaries, and support IEN's licensing and assessments. And between January 2023 and January 2024, BC have registered more than 1,700 IENs with the BC College of Nurses and Midwives. And of those, 800 received full RN or LPN registration upfront, up from 288 in 2022. And the third step is the provincial health human resources strategy. In BC, the province launched a long-term HHR strategy, health human resources, in September 2022, built around 4 pillars: retain, redesign, recruit, and train. As part of this strategy, the aligned health workforce, which includes internationally educated aligned health professionals, such as physiotherapists, lab technologists, and many more, is being explicitly targeted. The Aligned Health Strategy Plan promised bursaries, a new bursary program for international educated physiotherapists, and the financial support for regulatory assessment fees. And the scale matters, and BC estimates support for as many as 400 internationally educated aligned health professionals in the first year just through its physiotherapist bursary program, and with more support to come for lab technicians and other need professions that our BC government needs. And the fifth point, dedicated provincial support offices and financial supports. If you look at the Manitoba government provides a strong example. Their careers for internationally educated professionals, i.e. IEPs program offers up to $23,000 in non-repayable financial assistance to cover the assessment, training, bridging, exam preparation, workplace placements, and even the living expenses, childcare, or transportation if needed. And on the regulatory side, the College of Registered Nurse of Manitoba recently expanded expected registration pathways for IDNs, including those trained outside of Canada, and increasing the eligibility and the streamlining licensure. And with the example of Manitoba government, these supports demonstrate that provinces are investing real money, not just policy commitments, but to reduce the barriers of IHP so they're able to integrate into our health workforce quickly and fairly. Next slide, please. The policy and the governance and landscape. When we look at the current landscape of IEHP integration in Canada, one of the biggest challenges is the fragmented regulatory environment. Across this country, we have over 30 different health regulatory bodies, each operating at the provincial or at the territorial level. Every one of these regulators has its own standard assessment requirements, timelines, and eligibility criteria. There is no single national framework for a credential assessment, practice readiness, or a clinical evaluation. For internationally educated professionals, this means that pathways can be very dramatically depending on where they settle. The same qualification might be recognized quickly in one province, but require additional assessment or courses in another province. This creates duplication, long delays, and inequality for IHPs, simply because health regulation is not standardized across Canada. It also limits the labor mobility. An IHP licensed in one province may still face barriers if they want to move to another province with different roles. This fragmentation becomes even more complicated when we look at the federal, provincial, territorial dynamics. In Canada, immigration is federally managed, while health workforce regulation is provincial responsibility. This means that two systems, federal immigration pathways and provincial licensing pathways, operate independently, and sometimes their priorities don't fully align. And for example, the federal government might recruit IHPs through the immigration programs, which they are doing right now, that prioritize healthcare occupations. But once these individuals arrive in different provinces, they often face provincial regulatory process that were not designed to integrate large numbers of IHPs quickly. We also see the coordination gaps between the IRCC and ESDC government, ESDC Canada, and the provincial health ministries. Each department plays a very pivot role. Immigration, labor market programming, and health workforce planning, but the systems don't always communicate seamlessly. These overlapping responsibilities create bottlenecks in assessment, delays in licensure, and challenges in matching immigration targets with provincial targeting capacity and labor market realities. This is why improving the FPT coordination constantly identified as one of the most important steps in strengthening IHP integration across this country. Next slide, please. Okay, and to continue, when we look at how Canada is responding to the challenges in IHP integration, there are several key policy developments and emerging coordination efforts that are shaping national landscape. First, we have the Pan-Canadian Recognition Initiatives. I'm sure a lot of you guys are hearing this word Pan-Canadian. And one of the most important is that the Pan-Canadian framework for the assessment and recognition of foreign qualifications. This framework sets out principles for fairness, transparency, consistency, and timelessness in credential recognition. It provides a very strong guidance, but the challenge is that it is not legally enforceable. This means that each province and regulators can choose how much of the framework they adopt, resulting in uneven implementation across this country. The federal government is trying to bridge some of these gaps through the FCR program, which funds projects aimed to improve IEHP pathways. So then programs like PICS, like FCR, and any other foreign credential recognition program across this country are part of this national effort, basically to reduce the barriers and support faster pathways into regulated healthcare roles by providing all the support services and the financial support they need and providing the Canadian work experience. Another major issue shaping policy is the lack of national data system. Yes, I've mentioned that Health Workforce Canada do have a national data system. However, not very strong. Right now, Canada does not have a centralized way to track the IEHP's journey from arrival to assessment, licensure, and eventually employment. Instead, the data is scattered across immigration system, regulatory bodies, training institution, and employers. And this fragmentation makes it very difficult for government, for service providers to plan effectively or forecast the workforce needs. And without the ununified data system, it is challenging to know how many IEHPs are stuck in assessment backlogs, where they are stuck currently, and what are the future solutions that the government can provide, and how many require bridging programs, or even how many successful enter the workforce. And to address these gaps, we are seeing emerging policy innovations across provinces. Several provinces are piloting accelerated pathways, such as bridging programs and practice-ready assessment. For example, BC has expanded PRA assessments for internationally trained physicians, while Ontario has introduced programs like supervised practice experience partnership, which allow internationally educated nurses to gain supervised clinical experience as a pathway to licensure. And at the federal level, recent budget investments, including the funding in the 2023 to 2025, are specifically focused on streamlining the credential recognition specifically for nurses and physicians, two of the most urgently needed professions here in Canada. And these investments aim to reduce the processing time, expand assessment capacity, and strengthen coordination between the regulators, employers, and the training providers. Next slide, please. Thank you. The Pan-Canadian Recognition Frameworks. The National Recognition Framework is a landmark initiative led jointly by federal, provincial, and territorial governments. Its primary aim to create consistent, transparent credential recognition system across Canada, addressing the challenges IEHPs face when navigating multiple provincial regulatory systems. One of the key benefits of this framework is that it reduces the duplication and the streamlining licensure for IEHPs who've moved between provinces. Instead of repeating assessment or retaining the unnecessary, IEHPs can now have their qualification recognized more efficiently, saving time, resources, and money for both professionals and the regulators. The framework also encouraged collaboration among the regulatory bodies, employers, and the educational institutions. By aligning assessment standards, bridging programs, and clinical placements opportunity, it ensures that all stakeholders work together to support the integration of IEHPs. And importantly, the framework emphasize again fair, competency-based assessment rather than requiring prior Canadian experience. This approach focuses on the actual skill and knowledge that professionals bring, ensuring that the IEHPs are evaluated based on their abilities, not just the location of their training or work experience. And finally, the framework also do help provide mobility, labor mobility, and workforce alignment within Canada's healthcare system by making it very easier for IEHPs to move between provinces and enter practice more quickly, and addressing staffing shortage, strengthening across access to care in unserved regions, and contributes to more sustainable, flexible, and resilient health workforce. Next slide. So roles of employers and our service providers, what can we do? And what are the roles that we should do to support the faster integration of IEHPs? Employers, they're the frontline workers. They're on the front lines. They provide supervised practice and mentorship opportunities, such as I mentioned, Ontario's Supervised Practice Experiment Partnership or hospital onboarding programs, which allows internationally educated professionals to gain hands-on experience while meeting the licensure requirements. Employers also create inclusive hiring pathways that recognize international experience, ensuring that skills acquired abroad are valued. And what can we do, the service providers and the settlement organizations? Well, we can complement this work by preparing and guiding IHPs through the system. They deliver pre-arrival and the post-arrival supports, including the credential evaluation guidance, licensure guidance, and job search training. They help IHPs navigate complex regulatory system and connect them to the bridging programs or employers' opportunities. Service providers also offers mentorship, networking, and obviously broader settlement supports such as housing, childcare, and community connections. They provide the advocacy and the coordination between the IHPs, employers, and licensing bodies, and also to collect data and feedback that help the government refine integration policies. Essentially, these service providers ensure that IHPs don't face the system alone, and they turn the information they have into the empowerment of our clients of IHPs. So altogether, employers and the service providers open the doors to experience and employment, while service providers guide IHPs through the pathways to reach the doors. Both roles are very essential to creating a system where IHPs can fully contribute to Canada's health workforce. Next, please. Next thing. Yeah, we can skip this. I don't believe we don't have a lot of time. Yeah. Yeah. So Danielle, do you wanna jump in here or? Oh, I guess I will do it.
Are you good? Would
Oh,
you like?
yeah.
Yes. Thank you, Min,
Oh, yeah.
for that presentation. Such great content. So that brings our presentation to an end. On the last slide here, you'll see the partners that are involved in the tri-provincial project that we are currently running. Please take a picture of this slide if you'd like to get additional information regarding the project, the Foreign Credential Project. And with that being said, we would like to now open up the floor for any questions, comments. But again, thank you all for joining us. Okay. I'm not seeing any questions. Any questions?
We don't have anything to.
No.
Yeah, I think you could get that.
Okay. So I think this just means that our presentation was very fulsome. Thank you all again for joining, and I wish you a great evening and safe travels back for those of us that traveled to Halifax. Thank you.